Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity series of CNS examination, today we'll be talking on reflexes, introduction, and then examination of superficial reflexes. So superficial reflex and mainly plantar reflex we'll be discussing in little more detail, and we'll be giving a little idea regarding what are the reflexes. So this is a reflex arc. Here is a sensory stimulus. This is sensory nerve. This is posterior root ganglia. This is the posterior spinal root. This is posterior horn. It makes a synapse with interneuron, and then it will make a synapse with anterior horn cell. So this becomes a polysynaptic, and then anterior horn cell will give alpha motor neuron to muscle. So reflex elicited by stimulation of sensory, or we call receptor, that we will call as superficial reflexes. So plantar reflex is one of the variety of superficial reflex. We'll be talking under certain headings: definition, little anatomy, types of reflexes, then method of examination, interpretation, localization. Especially we'll be talking more on superficial reflex in this chapter. Now reflex is an involuntary motor response initiated by a stimulus. Now when you stimulate the tendon or tendon receptor, we call as a deep tendon reflex or motor reflex, while when you stimulate the skin receptor, we call superficial reflexes. So corneal and conjunctival reflex is a variety of superficial reflex. Knee jerk, ankle jerk, bicep, tricep and supinator, they are deep tendon reflexes. Plantar reflex is a variety of superficial reflex. So in a superficial reflex, we have got one interneuron, so it becomes polysynaptic. This is one synapse, this is second synapse. So it becomes polysynaptic. Stimulus is receptor in skin, and response is a contraction of a muscle. And this particular superficial reflex is affected by descending tracts, and one of the pathway of sending a sensory input to the brain is by ascending tracts. So reflex whose arc passes through the spinal cord are called spinal reflexes, and if there is a reflex arc in the brain stem, then we call brain stem reflexes, or we call cranial nerve reflexes. There are some classical superficial reflex in a brain stem, or we call cranial nerve reflexes, and some reflexes are concerned with spinal cord, so we call spinal cord sensory reflexes. So superficial reflexes, deep tendon reflexes, we never discuss on a visceral reflexes. There are some visceral reflexes also. So this is a diagram showing you superficial reflex. This is deep tendon reflex, which is monosynaptic. And for a reflex, you require a receptor. In a deep tendon reflex, muscle spindle, afferent fibers, center, efferent fibers, that is motor nerve, and effector, that is extrafusal fiber of muscle. These are the 5 components for deep tendon reflex. If you replace this muscle spindle receptor by a skin receptor, it becomes superficial reflex. Component of superficial reflex: receptor, activation of sensory neuron, informing processes, activation of motor neuron, and response by an effector. So that will be regarding a superficial reflex. And you have got one interneuron at the level of spinal cord. So we call that as a polysynaptic reflex. So deep tendon reflex is monosynaptic, while superficial reflex is polysynaptic. Simple reflex arc. Now if you look at this, this is sensory, this is motor, this is mono, this is poly. So when you are stimulating the tendon receptor, it gives rise to a stretch receptor of tendon. We call tendon receptor in a tendon, and that will stimulate. It will pass the stimulus via the sensory nerve, we call efferent, to posterior root ganglia. From there to the posterior horn, this will be concerned with tendon. So this is called tendon reflex or a stretch reflex or a deep tendon reflex. Or you can also use the word motor. And then it will make a synapse with the anterior horn, and alpha motor neuron from anterior horn will supply a muscle, and muscle will undergo contraction and you will get extension at knee. This is called motor reflex. You can see these are the muscle spindle which will be stimulated when you stretch the tendon. And also there will be what we call as tendon receptors, and that will pass on the impulse to anterior horn cell and it will produce a reflex arc. At present we are not going into detail. The gamma motor neuron takes part in maintenance of tone, while alpha motor neuron takes part in reflex arc. And these there are called Golgi tendon organs, as well as the fiber from muscle spindle will take part in reflex arc. And there will be two types of descending fibers which helps in maintenance of tone in muscle. So there will be descending tracts which will be acting on the anterior horn cells, which will be taking part in maintenance of tone. And also there will be alpha motor neuron which will take part in a reflex arc that will be concerned with deep tendon reflex. There is visceral reflex where you get a stimulus which pass through the posterior horn, will make a synapse, and then you will have from lateral horn the fibers which will take part in what we call as autonomic reflexes or visceral reflexes, and they will be acting on glands, blood vessels, etc. via post-ganglionic sympathetic innervation. So we can divide the reflexes into superficial reflex, deep reflex, visceral reflex, and pathological reflex. Anatomically segmental, intersegmental, and suprasegmental. According to the number of synapses, asynaptic, monosynaptic, bisynaptic, and polysynaptic. And depending upon the response, flexor, extensor, writing reflex, postural reflex, withdrawal reflex. And there is one more called conditioned and unconditioned reflexes. Mainly we use two common words. We call superficial reflex and deep tendon reflex. We use only these two common words. And at the maximum we call monosynaptic and polysynaptic. All these other are for your theoretical purposes. And mainly it is a part of your oral exams. Conditioned reflex are acquired reflex, while unconditioned reflex are inborn reflexes or inherent reflexes. Secretion of saliva when the food is taken or kept in the mouth is unconditional reflex, while secretion even with a thought of taking a food is conditioned reflexes, and that is a form of acquired reflexes. We'll be talking of mainly superficial reflex, which we will divide into two groups. So I'm skipping over Babinski or extensor plantar reflex is called pathological. Among visceral, you can put pupillary reflex or light reflex or accommodation reflex as a visceral reflex. So we'll be talking on sensory or superficial reflex in detail in this particular chapter. And visceral reflex are also called autonomic reflexes. So in superficial reflex, we'll be discussing on abdominal reflex mainly, then cremastic reflex. We'll be just giving idea regarding bulbocavernous, anal reflex and plantar reflex. While deep tendon reflex we'll be discussing in a separate video lecture. That will be tricep, bicep, supinator in upper limb, and in lower limb knee jerk and ankle jerk. So sensory or superficial reflexes, deep tendon reflex are also called stretch reflex. Some of the reflexes we always mention in upper motor neuron, that is Babinski or we call plantar extensor. There is one more we call as a Hoffman reflex and Georgia, exaggerated Georgia. There are some release reflex because of damage to the frontal lobe. So they are called frontal lobe release signs like grass reflex, snout, suck reflex and palmomental reflex, which are mainly done in the children. Now talking regarding a superficial reflex we divide into two: cranial nerves involved with cranial nerves or brainstem reflexes, and we call spinal nerve reflexes. In brainstem reflexes, we do what we call as a pipillary reflex or light reflex. And then there are two other reflexes, corneal and conjunctival reflexes, which is concerned with fifth cranial nerve is a sensory pathway, seventh cranial nerve is motor pathway. And there is one more reflex which is concerned with 9th and 10th cranial nerve, that is palatal reflex or pharyngeal reflex, or together we call as a gag reflex. This is concerned with 9th and 10th cranial nerve. So sensory pathway is 9th cranial nerve, motor pathway is 9th and 10th cranial nerve. While ciliospinal reflex, sensory is a sensory stimulus in the skin of cervical region, that is the neck, lower part of the neck, and response is in the form of dilation of the pupil, which is by a sympathetic system, which is supplying dilator fibers of pupil, dilator pupil. But mainly we look for pupillary reflex, corneal and conjunctival reflex, and we look for the gag reflex. While in a spinal cord, abdominal cremastic reflex. Anal, bulbocavernous are usually not performed. So we look for abdominal reflex and plantar reflex. So we'll be going through that. In cranial nerve, we have already discussed the second cranial nerve and third cranial nerve, that is pupillary reflex. When you throw the light, you are stimulating the second cranial nerve. Then via optic nerve, optic chiasma, optic tract, lateral geniculate body, and then fiber will end into upper part of the midbrain, that is third cranial nerve, we call as third cranial nerve, and from there it will supply both sides constrictor pupillae, and it will give rise to constriction of pupil. I am not discussing in detail, we have already discussed in second cranial nerve. Corneal reflex, you stimulate the cornea part, and in conjunctival we stimulate the conjunctival part. Sensory pathway is fifth cranial nerve, motor is seventh, which is supplying orbicularis oculi. Center is pons, and the response is closure of the eye. While in palatal reflex, when you touch the soft palate, it is called palatal reflex. When you touch the posterior pharyngeal wall, it is we call as a pharyngeal reflex. The sensory pathway is mainly 9th cranial nerve, Motor pathway is 9th and 10th, where you get contraction of the pharyngeal muscle, which is by vagus, and contraction of soft palate, 9th plus 10th cranial nerve together. So this will be combined, and the center is upper part of medulla, and the response is contraction of the pharynx and contraction of the soft palate, giving rise to gagging. That's why it is also called gag reflex. But depending upon what you are stimulating, you call palatal when you stimulate the soft palate, you call pharyngeal reflex when you stimulate the pharyngeal wall. Same thing in a corneal and conjunctival reflex. You stimulate cornea, it is corneal reflex. When you stimulate the conjunctiva, it is called conjunctival reflex. Ciliospinal reflex, we are stimulating the cervical fiber or cervical sensory nerve. That is by stimulating the skin in the neck region, in the lower part of the neck, or we call lateral triangle of the neck. And response is by sympathetic system, which will stimulate the constrictor fiber, dilator pupillae fiber, and gives rise to dilation of the pupil. So the center ideally is in the spinal cord, and from there the motor pathway is via the sympathetic fiber. Hence it is called ciliospinal reflex, because the sympathetic fiber is via the ciliary ganglia to dilator pupillae. So this is mainly important while identifying a person with Horner syndrome, where you get the damage to sympathetic roots, and that gives rise to absence of ciliospinal reflex in Horner syndrome. Doll's eye movement and caloric test done in an unconscious person is also one variety of a superficial reflex only, but there it is a stimulation of a vestibular apparatus which is giving rise to oculocephalic reflexes. That's why this is not included in superficial reflexes, but it is a part of cranial nerve reflexes. So we have discussed regarding conjunctival reflex, corneal reflex, pupillary reflex, direct and indirect reflexes, and accommodation reflexes. All this we have discussed in cranial nerves. So go through. This is also a very good slide giving you the entire idea regarding the superficial reflexes concerned with cranial nerves. These are the other reflexes we call as a palatal reflex, or we call pharyngeal reflex, combined together gag reflex. This you are touching the cornea, so this is corneal reflex. This you are touching the conjunctiva, this is conjunctival reflex, and this is the gag reflex. This is pupillary reflex. As far as the superficial reflex is concerned with spinal cord, anal, bulbocavernous, plantar, cremastic, abdominal, and scapular. By and large, we perform only two common most, that is we call plantar reflex and abdominal reflex. But we'll be just giving you little idea. So anal reflex is by stroking the skin or scratching the skin near the anus, and response is contraction of the anal sphincter. So root value we call S3 S4 segment. While bulbocavernous is pinching the dorsum part of the glans penis, you get the contraction of the bulbocavernous muscle, and that is again S2 S4, S3 S4. Plantar is L5 S1, but we'll be discussing in detail in plantar response, that is stroking the sole part of the foot and toe, leading to flexion of all the toes, plantar flexion of the foot, with many more things. We'll be discussing that part. In cremastic reflex, we stroke the skin in the upper and inner part of the thigh, and the response is upward movement of the testis because of the contraction of the cremastic muscle, and the root value is L1 L2. Abdominal reflex segment is right from T8 to T12, and it is stroking the abdominal wall from lateral to medial, in different direction and you get a contraction of abdominal muscle, and which you can observe by movement of umbilicus. While scapular reflex usually not done, it is a stroking a skin in the interscapular region. You get the contraction of the scapular muscle and the root value is C5, C6, C7, C8 and T1. By and large, this is not commonly being done. So plantar reflex, abdominal reflex, scapular reflex, anal, cremastic and bulbocavernous. Again same is repeated, root values, how to elicit and what are the responses. I've already mentioned before, so we have already mentioned. Same thing is mentioned here, abdominal reflex, cremastic reflex, anal reflex and plantar reflex. So this is an abdominal reflex. Only you should know that whenever you are stimulating, it should be from lateral to medial. Means from outside towards the center. That should be the way. This upper part is T8, T9, T10 and lower part is T10, T11 and 12. So umbilicus is T10, xiphisternum is T8 and pubic symphysis is T12. So depending upon that, you look for the responses. If abdominal reflex is absent, it is indicative of upper motor neuron palsy. We'll be talking of that. Normal response, contraction of abdominal muscle and resulting into movement of umbilicus. The abdominal reflex will be absent in both central and peripheral nervous system damage. In central we call as upper motor neuron, and if there is a damage at T8 level, T8 to T10, upper abdominal reflex will be absent. At the level of T10, central abdominal and lower part of abdomen, T10 to T12. It will be also lost in upper motor neuron lesion. In obesity, it will be difficult to elicit. In elderly person also, it will be difficult to elicit. And any person who has got a very lax abdomen, or if a person who has got a tense ascites, then also abdominal reflex will be very difficult because there will be poor contraction of abdominal muscle. So this will be some of the conditions where there is no neurological damage, but it will be difficult to elicit. Obesity, elderly person with a very lax abdomen and tense ascites. So these conditions should be also kept in mind while eliciting the abdominal reflex. You can see the direction of stimulus from lateral towards the center. This is diagonal stimulus and you look at the movement of umbilicus because of contraction. So go from lateral towards the center. This will be T8, this is T10 and pubic symphysis is T12. So absent reflexes in abdomen, remember to damage at the level of spinal cord and in case of upper motor neuron, because one of the pathway of sensory to brain is via ascending tracts and descending fibers are via pyramidal tracts. Similar thing in cremastic reflex, you scratch on the upper and inner side of the thigh, you get the testis is being elevated, stroking the skin in the upper and inner part of the thigh, you get contraction of cremastic muscle and testis is lifted up. If it is absent, classical in case of upper motor neuron lesion or lower motor neuron, because the root value is L1, L2. So lower motor neuron damage at the level of lumbar 1, lumbar 2 will produce absent cremastic reflex. And in a condition where you get disorders of scrotum like huge hydrocele, inguinal hernia, etc., cremastic reflex will be difficult to elicit, and that you have to always, while eliciting, you will have to look for that. That is regarding a cremastic reflex. Bulbocavernous by and large not done, and in a bulbocavernous the root value is S3, S4. Some say that right from S1 to S4. So damage to S1 to S4 will produce absence of reflexes. and also it will be absent in a upper motor neuron lesion. So when you pinch the bulbocavernous part, you get the contraction of the bulbocavernous muscle, and that is a positive response. And if it is absent, classical in case of a upper motor neuron lesion on that side. Anal reflex, again scratch the skin around the anus, you get the contraction of the external anal sphincter. It will be absent in upper motor neuron. It will be also absent in lower motor neuron if there is a damage at S2, S3, S4, and in cauda equina, that is a lower motor neuron damage of S2, S3, S4, anal reflex will be absent. Superficial reflex will be elicitable, means we call as present, that is normal. If it is not elicitable, one in damage like upper motor neuron or lower motor neuron, and it will be also not elicitable if your method is wrong, we call it a false technique, or there is a damage to sensory root or motor root or the spinal cord center. So if there is a damage to sensory root or motor root or the spinal cord center, we call it a lower motor neuron. And when there is a damage to pyramidal tract above the center, we call as upper motor neuron damage. But at the level, say at the level of sacral 2, 3 and 4, anal reflex, bulbocavernous reflex, as well as cremastic reflex. Cremastic reflex at the level of L1, L2, while bulbocavernous and anal reflex will be S2, S3, S4. So if there is a damage at the level, you will have either damage to the sensory root or the motor root or the spinal cord center. But above that center, if you say get the damage at T12, then it will be absent because of the damage to pyramidal tracts. So then we'll call that as upper motor neuron damage. Also we have mentioned that in a case of obesity, tense ascites, gross distension, very lax abdomen, anxiety, non-cooperative person also, abdominal reflex will not be elicitable. So superficial reflex can be present or absent or not elicitable. These are the three possibilities. Present means normal, absent means either upper motor neuron damage or lower motor neuron damage at the level of reflex R, and not elicitable in a non-neurological conditions. So keep that thing in mind. Now we are coming to the main part, very frequently asked in a theory, in oral exams, and if you want to differentiate upper motor neuron and lower motor neuron, we always look for plantar reflex. Spinal cord root value is alpha S1. The method of eliciting is by and large the best method is always in supine posture. Leg is extended at knee and extended at hip. You hold at the ankle. You stroke the skin from the heel laterally along the lateral border of the foot, or we call plantar surface of the foot, towards the small toe and then towards the great toe in one single stroke by a blunt object. So in supine position, gently scratch the outer border of the foot with a blunt object, starting from the heel towards the little toe and then medially up to great toe. During this particular, you get a response we call as a plantar flexion of all toes. So if we combine together, now here we are mentioning sensory root is tibial now, segment is alpha S1, and efferent is also tibial now. So if you get the damage to tibial now or spinal cord segment alpha S1, plantar reflex will be absent. We call that as lower motor neuron. And if there is a damage above L5 segment, then it will be upper motor neuron. So if we mention all the components, I'll go directly to the components. Sorry, this is Babinski's sign. So normal component, yes, this is normal component. So plantar flexion of all toes, plantar flexion of great toe, adduction of all toes, plantar flexion of foot, plus contraction of tensor fasciae lata where we call is the lateral side of the thigh. All this combined together, plus there is a withdrawal at knee and hip, that is flexion at knee and flexion at hip. All these are the component of normal plantar response. Again I am repeating, plantar flexion of all toes including great toe, adduction of all toes, plantar flexion of foot and contraction of tensor fasciolata with withdrawal response in the form of flexion at knee and flexion at hip. While extensor response, or we call Babinski sign, or we call abnormal response. So plantar extension of all toes, particularly of great toe, abduction of all toes, plantar extension of the foot, absence of contraction of tensor fasciolata, and withdrawal at knee and hip. This is non-specific. So we have to pay attention to these responses, and that we call as Babinski sign, or we call Babinski reflex, or we call abnormal plantar response or plantar extensor. These are the words. I'm going back, I'm showing you all those things. You can see here, this is a normal response, means there is an adduction, plantar flexion of great toe, plantar flexion of the foot with withdrawal and tensor fasciolata. While if you get abduction of all toes, plantar extension of toes, extension of the great toe, plantar extension of the foot and absence of contraction of tensor fasciolata with withdrawal will be plantar extensor, or we call Babinski sign. So look for that response, and you have to stroke the skin from heel laterally to the small toe and then towards the great toe in one single stroke by a blunt object. So this is normal response, this is abnormal response. So you try to, and while eliciting the reflex, you hold at ankle to reduce the withdrawal reflex or to prevent withdrawal reflex. So dorsiflexion of great toe with or without extension and fanning of other toes, dorsiflexion at ankle, flexion at knee and contraction of tensor fasciolata is Babinski sign, or we call Babinski reflex. And you can elicit that if there is an upper motor neuron palsy by different other modes. You can show that there is extension of the great toe. When you tap over the lateral malleolus, it is called Chaddock's sign. When you apply a firm pressure on the shin of tibia, it is called Oppenheim test. When you flick the terminal toe, it is called Gonda's test. When you tap with a hammer on terminal toe, that is called Rosolimo. And you squeeze the calf muscle, Gordon test. And you squeeze the tendo achilli, it is called Schaefer test. These are some of the tests in upper motor neuron you can elicit, and they will be much better elicitable in children. And we have got one video, will be showing you that. So this is a typical response which you get. You can see here the toe is going extensor. This is Babinski. But plantar response will be absent if there is a complete loss of sensation in the sole part of the foot, like in severe peripheral neuropathy, or if there is a damage at the level of S1, S2 in spinal cord, or if there is a paralysis of extensor hallucis longus. And we have already told you, if there is a damage to L5, S1, that is plantar response. So if that is damaged, you will have absence of plantar response, or plantar reflex will not be elicitable. At the same time, we should be aware of person. Plantar reflex will be difficult to elicit in a non-cooperative person, or if there is method is wrong. So flexor response is normal. Absent is damage to the sensory pathway of plantar surface of the foot, or nerve supply to the foot, or spinal cord damage at the level of S1, S2. And plantar reflex will be extensor In case of a pyramidal tract damage, that is unilateral extensor. But bilateral extensor in case of a deep sleep, coma, newborn children till he starts walking, post anesthesia, during anesthesia and post anesthesia, it will be good number of time bilateral absent, post ictal coma. Also in case of a pseudobulbar palsy, it may be bilateral extensor, and in a case of a paraplegia because of bilateral pyramidal tract damage, it will be bilateral extensor. Now this is a, just listen to this. Sorry. So I'll show you that. Just 1 minute.
Now, it is an extensor plantar reflex which is seen in upper motor neuron lesions due to injury or affection of the corticospinal tract due to any other reason. To revise, the corticospinal tract is a descending motor tract which originates from the cerebral cortex, passes via the brainstem reaching up to the spinal cord, from where the lower motor neuron begins in the form of peripheral nerves. These fibers maintain inhibitory control over the spread of the impulses from the dermatome, which is stimulated, to other levels of the spinal cord. For example, in eliciting the plantar reflex, we give nociceptive stimulus to the lateral border of foot, which is the S1 dermatome, which normally causes plantar flexion mediated through S1.
This is normal response. But if there is a damage to the descending tracts, that is pyramidal tract, you will have plantar extensor,
where afferent is S1 and efferent is via S1 and tibial nerve, root value L4, 5, S1, 2, 3. Once the corticospinal tract is affected, the inhibitory control is lost and firing spreads onto L4, L5 anterior horn cells, leading to the contraction of toe and extensors, that is, extensor digitorum longus and extensor hallucis longus via the deep peroneal nerve. The Babinski sign has 5 components.
These are the 5 components of Babinski sign. Dorsiflexion of great toe,
extension and fanning
with
of the
extension
toes,
and fanning of other toes, dorsiflexion of
flexion
foot,
of knee, and
flexion
contraction
at knee
of the tensor fasciae
and hip
lata.
is
One must remember
a withdrawal
that
reflex,
extensor
while
plantar
contraction of
response
tensor
is
fasciae
called as
lata.
Babinski's positive. A flexor plantar response is not known as Babinski's negative. So there is no term as negative Babinski sign. Babinski sign
Either
is
we
the
say
same as
Babinski
Babinski's
sign or
reflex,
we call
and it
Babinski
is a
positive.
superficial reflex. We will show various superficial and deep reflexes in a subsequent video. To elicit it, the plantar surface of the foot should be free of
Always
any
person
pathology.
should be
Eliciting
lying
should
down,
be sharp but non-traumatic.
extension
For
of the
example,
full
the tip of the hammer handle,
limb,
or preferably the tip of a cage.
part should be exposed.
Make the
hold
patient
that
lie
ankle,
relaxed on a couch, explain the procedure,
explain
and
the
stroke the
procedure,
lateral
and
plantar
then you
side of the
strike
foot
the
from
lateral
the heel
surface
to
of
the
the
toes
plantar
and
side
then across the
of the foot
metatarsal pads
from
to the
heel
base
towards
of
the
the big toe.
toe and then across towards the great
So
toe.
this is
Now
how
you
the
can see
Babinski
that
sign is
how it
elicited
is
by stroking the
elicited.
lateral border
See,
of the
there is
foot
an
up to the base
extension
of the toe.
holding at the
Actually,
ankle.
the lesion in this
You can
patient
see
was
the
so
withdrawal
severe
at knee
that
and you have
even the
got plantar
slightest stroke on the
extensor.
lateral border produced the extensor plantar response. Sometimes even this much produces the response and you don't need to complete it up to the base of the toes. Even the maneuver does involve
Again,
completing it
if you
up to
want
the
to
base
see,
of the
I'll make it again. Sorry.
Shadok sign by rubbing down the shin of tibia. Movement should be sharp but non-traumatic. For example, the tip of the hammer handle or preferably the tip of a key. Make the patient lie relaxed on a couch, explain the procedure, and stroke the lateral plantar side of the foot from the heel
Again,
to
you
the
can
toe
observe.
and then
So,
across the
this is a
metatarsal
very
pad
good way of
to the base
eliciting.
of the big toe. So
Now you
this
can
is how
see
the
that
Babinski sign is elicited
leg
by
is made
stroking the
straight
lateral border of the foot up to the base
and
of the toe.
see the plantar,
Actually, the lesion in
that
this
is
patient was so
extension
severe that
of great toe,
even the
and
slightest stroke on
simultaneously
the
there is a
lateral
withdrawal
border
also,
produced the extensor plantar response.
and you have to hold it
Sometimes
at
even
ankle
this much
to
produces
reduce
the
that
response and
withdrawal.
you don't need to complete it up to the base of the toes. Even the maneuver does involve completing it up to the base of the toes.
Now those different methods
What if the
is
foot is
eliciting.
infected or injured and we cannot elicit the Babinski sign? In
So
that
if the
case,
foot is
there are some
infected
other
or
signs
injured
by
because of
which we can
pain,
elicit the
person will
extensor
not allow
plantar
you to do
response,
the plantar
some of
reflex.
which are demonstrated
So
here quickly.
you can elicit other. This is open
Open
hem.
heel sign
You are
by rubbing down the
you can
shin
see
of
that there is
tibia.
an extensor. This is open hem sign.
Gordon sign by
You
squeezing the
squeeze the
calf
calf
muscle.
muscle, you see the extensor. That is Gordon.
Shadok sign by stroking the lateral malleolus.
You strike the lateral malleolus, there will be extensor. You can see the extensor. That is Chaddock. You can see extensor.
Bing sign by pricking the dorsum of foot.
This is Bing sign.
Gonda sign
Gonda
by
is
forceful downward
flicking the
stretching of the second or the fourth toe.
flicking the terminal toe or last toe.
And finally, the
Shaper,
Sheffer sign
that is
by
squeezing
pressing the
the
tendon
tendoachally.
reflex.
You can see very nicely these signs are elicitable.
Then there are some other signs which are
These are all the
not
other
generally
signs.
asked in the
If you are
examination but are
interested,
mentioned
you
in
can
case
have a
you wish to
pause
know.
and you can go through.
So what are the advantages of eliciting the Babinski sign? First, it is a simple bedside clinical sign.
Beautifully
Second, it
shown.
has an improved
Beautifully
accuracy
shown.
when compared against electromyographic
I'm
findings.
very
And a
thankful to the
true
person who
upwelling
has
toe sign is
uploaded this video.
reproducible, unlike voluntary withdrawal response, which the child might not be able to repeat in the same manner. But one must remember that sometimes there is no response to stimulation, and this is referred to as neutral response. This response, however, does not completely rule out the pathology. So when can it be falsely positive?
False
There are a
positive.
plethora of causes, but as
In
pediatrician we
children, we have
must
already
know
mentioned.
that age less than
Deep
1 year is an
coma,
important cause, rather up to 18 months,
electroconvulsive
due to
therapy,
incomplete
post-ictal
myelination
stage,
of the
giant
corticospinal
stroke
tract.
breathing,
Sometimes
severe
it can also be
narcosis,
positive in deep
hypoglycemia,
sleep,
hypnosis,
coma under the effect of general
and also some
anesthesia,
of the
or even during the
physical
post-ictal phase
exhaustion
of seizure.
also
Remember,
can
one
have
common
absence
factor
of
is that the
false
corticospinal
positive.
tract has temporarily lost its negative control on the spinal cord in all these physiological states also. So would you like to know who discovered it? It was a neurologist, Joseph Francois Felix Babinski, who originally described it as the toes phenomenon or phénomène des orteils, but later eponymously referred to as the Babinski sign. Thank you for watching till the end and have a good
So thank you all for taking out time. I know that your time is valuable and I feel this will be very helpful to you in your oral exam as well as